Welcome everybody to a Diabetes Canada webinar. I'm very excited. We have Diana Sherifali here to talk about health coaching. So very excited to have you here, Diana. Before we get started, I'd just like to thank Nestle Boost for sponsoring today's webinar. Diana is an associate professor in the School of Nursing and the inaugural holder of the Heather M. Arthur Population Health Research Institute Hamilton Health Sciences Chair in Interprofessional Health Research. Dr. Sherifali is also the lead of the McMaster Evidence Review and Synthesis Team, which supported the development of guidelines for Diabetes Canada and Obesity Canada. She has been funded by Diabetes Canada, Heart and Stroke Foundation, the Canadian Institutes for Health Research, and more recently has been selected as an Emerging Leader 2020 by the World Heart Federation. Dr. Sherifali's research interests include the implementation and evaluation of strategies to optimize diabetes self-management at the patient through health coaching. So without further ado, Diana, take it away.
Thank you, Grace, for that kind introduction. It's an absolute pleasure to join everyone for this webinar and a pleasure for me to talk about health coaching. I've been a nurse diabetes educator for several years, and I've been passionate about supporting people living better lives with diabetes, or for those at risk for diabetes. So it's a delight for me to share a little bit about my clinical experience, but more recently, my research experience around health coaching. So to start off, I want to talk a little bit about context and background. I will then discuss the development or developing and evaluating a diabetes coaching model. This is still developing and still being evaluated in various forms. And then I want to conclude the webinar today with some reflections, some rethinking or reimagining of diabetes coaching, and then revising this for the future and what the future looks like. So I certainly don't need to tell this audience that in the grand scheme of things, we do see the cases of diabetes on the rise, type 1, type 2, gestational. We're seeing different forms of diabetes. So for the most part, where we're feeling a lot of pressures on the system are the rising rates or prevalence rates of type 2 diabetes. And really, you've heard the analogy of the perfect storm where, as a society, we're becoming a little bit more overweight, obese. We've had COVID, we've had, lockdowns. So all of this tends to be a perfect storm for this context of rising cases of type 2 diabetes. We also know that diabetes management in general requires a team-based care approach. And we know that this is really about engaging, empowering individuals to become informed and hopefully self-manage their diabetes. So at that point, self-management, if we dig a little bit deeper, is really all about an individual's ability to manage their diabetes, including their symptoms, their treatment protocols, adhering to treatment, adhering to the physical, activity, nutrition, but also help support themselves in terms of psychosocial consequences and well-being. And even saying that is overwhelming, let alone trying to live with diabetes and manage this. So to facilitate diabetes management as educators, we've often talked about, well, we need to distill the knowledge, the skills, the capabilities, assess readiness. We need to get a sense of people's empowerment or motivation, and then their problem-solving skills. In terms of diabetes self-management support, that support was really around supporting behavior change and goal setting. And our goals typically have been outlined as SMART goals that are really aligned closely with the clinical practice guidelines, whether it's nutrition goals, physical activity goals, medication adherence goals, and such. A little bit more about self-management. And this is really coming from, I would say, in the last decade or so, I have been writing a little bit about self-management and the evidence for it. It's based on a lot of other chronic conditions. And I make this point because I could certainly understand that people can argue that the needs and demands of chronic disease management vary from condition to condition. But I truly, in my heart of heart, believe that diabetes, whether it's type 1, and type 2 carry a myriad of challenges, problem-solving skills. As patients have said, the daily grind of managing their diabetes looks very different in comparison to other chronic conditions from which the self-evidence or self-management evidence comes from. So with that in mind, when we peel back the layers of the evidence, we see that there's a great variation and heterogeneity in terms of the methods and how those studies were done. And then subsequently, because the methods are variating so much, we have a harder time sort of distilling, understanding, trusting the results, and then subsequently, how do we implement that in actual real world settings where, for example, patients aren't being remunerated, their parking's not paid for, they're not given, football tickets or hockey tickets for completing trial assessments. So with that in mind, we know that by the time we take some of that self-management evidence and implement it in real world clinical settings, doesn't quite carry the same weight. We also know that one size does not fit all approach when it comes to self-management. And some of this comes down to the person and the circumstances. I can reflect as a young girl, going through the experience of my mom being diagnosed with type 2 diabetes. If you can imagine the movie My Big Fat Greek Wedding, I'm not Greek, but my family's from former Yugoslavia. I was that girl that would take cabbage rolls to lunch at school, and all I wanted was peanut butter sandwiches. So all of the education that my mom was getting was not relevant to her circumstances and her personal context. It was always a constant struggle of getting peanut butter in the house, unfortunately, and I didn't have it until later on in life. So this really reminded me of persons and circumstances and context as being important. We also know that the delivery method and content doesn't really reflect a one-size-fits-all. Some people benefit from a group or peer-based learning environment. Other people don't. Some people appreciate asynchronous learning. Some people like to be in that same context, so synchronous learning. We also know that there's many other organization and process barriers. So how do we book appointments for self-management? Are they based on A1C levels every 3 months? Are they based on daytime hours that are not conducive to people living with diabetes and their work schedules as well? So all of this gives us some insight in terms of context and what is essentially driving some of this literature for health coaching. So the origin story for me really lands on a couple of instances. One was as a young girl going through nursing school, always taking what my mom was learning about her type 2 diabetes management and reflecting it back to her in a way that was conducive to her, meaningful to her, and really context driven for her. A second point and sort of conflection point for me was in my postdoctoral fellowship under the supervision of Dr. Herzl Gerstein, we had a negative trial where it was an intervention in the community that was paper-based. And it wasn't until I spoke to a patient in the clinic after the trial, and he asked me, Diana, what were the results of that trial? And I, in so many words, explained to him that it was a negative trial. We, didn't find a difference between the paper-based guideline recommendations versus usual care, what they were assessing in the community. And his comment to me literally stopped me in my tracks. And he said to me, well, Diana, paper doesn't talk to me. And that set me on a whole other trajectory in terms of coaching. So in terms of talking, in terms of engaging, I also reflected on my own clinical experience as a certified diabetes educator. There were many instances where, we were reflecting sort of the pillars or the tenets of self-management, that people should acquire the skills, the competencies, the knowledge, and then off they go and self-manage. But there was something more there. For me, I would often call patients, particularly after starting insulin or after being discharged from hospital, calling them and just checking up on them, not from a diabetes standpoint, not from a policing standpoint, or are they compliant, but more, how are you doing? How's life now that you're back home? Or what does your life look like now that you've started insulin? So it was really about providing support beyond diabetes, but what was life like living with diabetes? And so all of this led me on this trajectory of coaching or health coaching. So when I explored the literature a little bit more, lo and behold, to my surprise, I found that it was really resonating and reflecting what I was thinking for all these years. It was a eureka moment for me, and I kept thinking to myself, where have you been all my life, so to speak? So health coaching isn't new. It's been around for a couple of decades and really comes out of the clinical psychology field. Now, I'm not a clinical psychologist. I don't pretend to be, but I think there are certainly elements to health coaching that people can acquire, can gain skills and education so that they have the skills and competencies for this. So very briefly, health coaching is described as being super, super patient-centered. It includes patient-determined goals. So it's not about me using a formula and SMART goals. It's about what's important to the patient. It incorporates self-discovery and active learning processes. And the self-discovery piece is absolutely earth-shattering for me. When patients and people with lived experience can come forward and say, you know what, this is what I'm seeing. This is what I'm reflecting on. This is what I'm toying with. What do you think? It's really about patients being the experts and driving that. It encourages accountability, but from a non-judgmental support. We're there as health coaches as a sounding board. So patients can bounce off ideas to help further crystallize behaviors or some of those smaller habits that they're looking to work on towards a bigger goal. What I love about this is that there's always some degree of education alongside coaching. So it is not the group-based 2-hour coaching sessions that I used to do. It's really about what I've coined as just-in-time education. And I've borrowed that terminology from industry, where they don't have a lot of inventory sitting alongside manufacturing lines, et cetera, but just the right amount of inventory and parts to put something together. So for me, this is really about you're coaching, you're supporting someone through that self-discovery learning process phase. You're putting in a little bit of education, enough that can continue the momentum around self-discovery and learning. And then ultimately, the healthcare professional is trained in behavior change, communication, and motivational skills. The second bullet point really talks and sort of further explains that it's about education, psychosocial support, and all about the individual's health-related goals. And then the final bullet point is what I've sort of coined, that health coaches, particularly in diabetes, are seen as care translators. So we're taking abstract clinical practice guidelines or goals or recommendations and translating it back to, what does this mean for the person in front of me? What does this mean for the individual living with diabetes? And maybe the word translation comes to mind for me from the standpoint of my mom. English is a second language, but I really feel that that's an expression or a term that really resonates with people. It's taking guidelines and recommendations or best clinical practices and translating it into a way that really means something to the individual living with diabetes. So I had a working definition, and I thought this really resonates with me. My next choice was to go to the literature to see how is this expressed in terms of clinical benefit at all, if at all, in the literature. So I embarked on a literature review of randomized controlled trials and found 8 randomized controlled trials that looked at interventions of diabetes health coaching. And of those 8 trials, we extracted the data, we numerically synthesized the data in a meta-analysis. Found was that if you were exposed to diabetes health coaching, it reduced the A1C by 0.57% if the intervention was longer than 6 months. If it was less than 6 months, it reduced your A1C by 0.23%. All of those results were statistically significant, and I would argue absolutely clinically significant as well. If you can encourage someone to access and work with a diabetes health coach and tell them that their A1C can drop by almost 0.6%, that's on par with some medication. And I would argue that there's greater benefit to working with a diabetes health coach than just taking a medication. Then in 2018, a few years later, colleagues, Pergablue, Ritvo, et cetera, from York University, looked at 22 studies. So they were a little bit more liberal in terms of their inclusion criteria. And what they looked at again was health coaching. So not necessarily health coaching that was diabetes specifically trained individuals, but just broadly health coaching to help people with type 2 diabetes. And they found very similar results. So again, at 3 months, there was a reduction in A1C of 0.3%. 4 to 6 months was a reduction of 0.5%. 7 to 9 months, 0.66%. And then anything 12 months and longer, that sort of magnitude or benefit of reduction weaned off. So what was interesting was we noticed longer term benefits 6 months or greater. Pergablue and colleagues noticed 4 to 9 months of that 0.5 or 0.66%. Again, very compelling to show us that, you know what, where there's smoke, there's fire. We're on to something here. So in addition to the meta-analysis that I did of 8 trials, I dug a little bit deeper. So not just a matter of, how well does this work in terms of glycemic control? I wanted to get a sense of why did this work? What was the secret sauce? And from this, I basically looked at all of the literature that was found in my systematic review and considered what were those core ingredients of coaching? What was the diabetes health coach doing? And the doing components fell into 4 broad categories. Those categories included case management and monitoring. So what the important thing to think about here with case management was in some instances helping people navigate the healthcare system, navigating referrals, navigating options in terms of when to seek additional support, when might they need additional help. But again, it was always done in a non-judgmental approach. So the monitoring component might be, let's talk a little bit about what's happening with your blood glucose levels. So it wasn't so much, let me see the levels, are you testing, are you taking your insulin, but rather that self-discovery, exploring what's going on with really the person living with diabetes driving the agenda. The second component of the diabetes coach model was self-management education. And this comes back to the whole idea of that just-in-time education. Not a lot, not too little, just the right amount, that sort of Goldilocks level, if you will. Behavior change was also a crucial component to this. And this is something that I really struggled with because I found behavior change difficult, even in my own personal life, playing athletics and varsity soccer, all the way up to, managing my own nutrition and physical activity as a busy mom with a career, et cetera. So behavior change to me became quite abstract and obtuse if I was looking at SMART goals and only seeing people every 3 months or every 6 months to work on their goals. So behavior change, I dug a little bit deeper into this. And what was remarkably notable by all of this was that it was not waiting 3-6 months to assess and support behavior change, but rather frequent interactions around behavior change. So those bigger goals quickly became small adjustable habits, if you will. The final component that really resonated with me in terms of what I was supporting people with was more than just the insulin, the glucose levels, the testing, but the psychosocial aspects of living with diabetes. And what really resonated with me was that people had stories to tell. People wanted to talk about their diabetes. They want to talk about their life living with diabetes. They wanted to talk about their life despite diabetes. And so this became an important aspect as well in coaching, that oftentimes it would be listening. So this was certainly articulated in the literature. And again, that concept that really rang true to me was care translator in all of these aspects. And this coaching model is published in the Journal of Diabetes in 2017. And then finally, what also came about after looking at the literature, distilling the components of coaching, was a working session in April 24th of 2017, where we had experts involved in the coaching space in diabetes and in obesity. And we included a bunch of subject matters, 20 interdisciplinary subject matters, including folks from universities, clinical practice, so research, clinical practice decision makers, all sorts of stakeholders and people with lived experience, to really look at if we were to create a pathway or an education program of health coaching for diabetes, what might that look like? And the result of that is a learning pathway that's described here in the box on your left side of the screen. And this is a learning pathway through the Health Coach Institute at York University. So I'm proud to say that I'm a co-founder of this learning pathway for health coaching for chronic conditions that could certainly be relevant for diabetes health coaching. I'm also very proud and happy to say that this is one of the only health coach professional certificates that are board certified, a handful in the world, and the first and only in Canada to meet the national standards for health and wellness coaching approved in Canada. So the totality of all of this then made me think, okay, with all of that in mind, with this crystallized, evidence-informed model, and knowing about the magnitude or that sweet spot when it came to the duration intensity of coaching, I thought I needed to go test this. So in good fashion as a researcher, I applied for funding and grateful for funding from the from CHR, our federal health research body, and partnered with the Community Health Center in Cambridge, Langs, and their community diabetes program, and received some additional support from Hamilton University. We embarked on a pragmatic community-based trial of people living with type 2 diabetes. Our criteria was that they had to have an A1C level of 7.5% or above. So a little bit above target, sort of guideline recommendations. They had to have access to a telephone, read, write English, and have accessed at some point diabetes education. And that was just simply to ensure that they were in a system where we could document and chart in an EMR. So we sought to recruit 340 participants, randomized one-to-one to usual care diabetes education. So they would initially come through classes, and then it was just ad hoc as needed or as determined appropriate by the nurse or dietitians in the local diabetes education programs. Or they could have access to a diabetes health coach for 1 year in addition to the diabetes education as needed. So as needed, sometimes they're back there at the education program once or twice a year, but it generally speaking was not sort of frequent touch points and contact points. Our primary outcome of interest was glycated hemoglobin A1C, again, that sort of 3-month marker of glycemic control. But our secondary outcomes really aligned beautifully with the triple aim. So we looked at patient-reported outcomes in quality of life, and we had 2 types of quality of life. We had a generic type of quality of life, but also a diabetes-specific called the ADQUAL. So we could look at generic, which we could then extract some of that data and use that for cost effectiveness. So that was the next component of our triple aim outcomes. So we had clinical care, or sort of care of the population outcomes, patient-reported outcomes, but we also had cost as well. We also wanted to capture what was actually happening at the behavioral level of the individual. And there we use the self-care behaviors tool to assess that as well. The results of this trial are published in the Canadian Journal of Diabetes, along with the protocol as well. So just very quickly, the intervention was happened to be delivered by a graduate prepared nurse. I think this could be a nurse that's prepared at an undergraduate level. I think the most important piece here is that they are a certified diabetes educator and have a good, solid baseline footing in diabetes education and training. They were trained in the coaching model and given additional support in motivational interviewing and behavior design. And this was a specific boot camp that was offered through BJ Fogg, a Stanford University professor who's done a lot of work with behavior design and tiny habits. This was delivered over the phone exclusively. So people actually never met the diabetes health coach in person. It was just strictly over the phone. Coaching was offered for about 15 minutes for once a week for the first 6 months. This was offered to individuals. And then once a month for the last 6 months. So there was a bit of a weaning off or tapering off in the last 6 months. And the thrust of the whole coaching intervention was that this was patient-driven. Every single phone call was started off with, how are you? How's your week going? Last week we talked about this. How are things going? So it was really driven by the patient for the patient. And the agenda, the topics, et cetera, sometimes would be indirectly related to diabetes or immediately jump into diabetes specific topics, but really all about the individual living with diabetes and what they wanted. So we recruited participants from May 2016, and then our final participant was recruited in December 2017. We actually went a little bit higher. We got to 365 participants. And you can see between the intervention in that middle column and the usual care group, the far right column, based on age, gender, race, diabetes duration, BMI, weight, and A1C, there were no statistically significant differences in the two groups. Although it looks like there are some differences, but none of those differences were statistically significant. I will also draw your attention to diabetes duration in terms of years. These are folks who had diabetes for 9-10 years on average. So you can imagine they've gone through multiple forms or durations of diabetes education. So what was really compelling was the fact that they still came forward and signed up for a diabetes health coaching trial. And in subsequent slides, you'll hear some of the feedback from individuals, which was really quite fascinating. So after receiving diabetes health coaching for 12 months, both groups improved their A1C. And we kind of knew that was going to happen. So the fact that they actually still had options and the opportunity to go for diabetes education, we weren't surprised by seeing both groups improve. However, the difference between both groups was a difference of 0.49%. So close to that 0.5% drop in A1C that we saw in our earlier meta-analysis. After adjusting for age, baseline A1C level, gender, ethnicity, BMI, and diabetes duration, the mean difference in change in A1C was virtually the same at 0.48%, both statistically and clinically significant. When we looked at the patient-reported outcome, in other words, was this of value to patients? How important was this for their quality of life? We saw a clinically and statistically significant improvement in the ADQUAL test, the Audit of Diabetes-Dependent Quality of Life. So this is a quality of life tool that's nuanced and detailed enough to pick up on some of those variations about what is it like to live with diabetes. So again, the change between the two groups was an improvement, an increase in 0.258 units of the ADQUAL. And when we dug a little bit deeper, we saw that there were meaningful, statistically and clinically different improvements in terms of the interpersonal relationship. So how people talked about their diabetes with others, how they were managing their diabetes around others. So we thought that that was very insightful. We did not see clinically or statistically significant changes in the summary of diabetes self-care activities. And this was noteworthy because we suspect that the self-care activities tool just wasn't detailed or specific enough to capture some of those nuanced things that people were doing. These are broad categories about monitoring your blood glucose. And we know that the whole intervention was more than just counting how many blood tests you've taken, how many times you've taken your medication. This was a more nuanced approach that was patient-centered. And then in terms of how this was actually used and implemented, what was quite fascinating is we estimate that people had access to the coach about 30 times in 1 year, if we factor in once a week for the first 6 months and then once a month for the last 6 months. The mean time or mean interaction counts was only 11. And that was fascinating in and of itself. People used the coach when they needed, how they needed. And the mean length of time per interaction, we allocated 15 minutes, was just over 10 minutes. So it was enough that if they were connecting with the coach frequently, it was just a quick touch base, tune up, fine tune things, gather some information, gather some reflections on that sort of self-discovery call, and then off they went. The most common type of strategy used by the health coach, if you go back to the model in those 4 components, the most prevalent component or strategy that was used was case management and non-judgmental monitoring. So again, we'll talk about the fact that patients valued that non-judgmental accountability. They got to check in with someone, but it wasn't a loaded or predetermined outcome. It was really about what they wanted to talk about on their terms. We also found that there was no statistically significant differences in emergency department visits or hospitalization. So for us, it was just as safe to offer diabetes health coaching. It was not an abdication of care. We weren't putting anyone in harm by using telephone-based only intervention to support people with diabetes. So in terms of reflections, in general, what we found was that in our trial, but also looking at some of the systematic reviews and meta-analyses, diabetes health coaching is an evidence and certainly theoretically informed intervention or strategy. The theory is there as it relates to health coaching, and there's more and more evidence that's accumulating for health coaching for diabetes in particular. So when people say diabetes health coaching or diabetes coaching, these are terms that are analogous with this broader form of health coaching. In our trial, we were successful in demonstrating that there was not only clinical improvement, but patient-reported outcome. So patients saw the value and felt that it was important in terms of improving their quality of life. We also had a subsequent study published led by Daria Riley, a health economist, looking at the cost effectiveness. And she demonstrated that telephonic support was absolutely cost effective. So on the grand scheme of things, you could argue that this is cost effective, improves glycemic control, and meets and is approved by patient reported outcomes in improving their quality of life. In subsequent interviews, and this is under peer review currently, participants expressed that diabetes health coaching supported the adaptation of living with diabetes. And this was really profound for me, particularly as I've reflected on my interactions with patients. These are patients who have lived with diabetes on average of 9-10 years, and yet they're still seeking support on how to adapt their lives around diabetes, not just around diabetes, but with diabetes, and how do they live their lives more optimally. What they also valued was offered non-judgmental support. So the offering of the coach to be there through thick and thin, good times, bad times, where their struggles, they could openly discuss and divulge what was happening and what they're thinking. They appreciated the guided behavior change. And again, I think with the frequent contacts, sort of the frequency, low touch contacts, quick fine tuning of some of those behavior design details really led to sort of broader goals. And then finally, patients enjoyed the fact that they were more mindful of what it is like to live a good, healthy life with diabetes. So they really talked about mindfulness of diabetes-related wellness beyond just the numbers and glucose tests. So where we're at now is rethinking, where do we go with health coaching? And obviously, in our our current health and human resource challenges in this sort of, COVID pandemic, we can't help but wonder, is there a way to optimize and further augment and support diabetes care? And what might that look like with diabetes coaching? So a couple things we're exploring is the use of technology-enabled collaborative care. We have a publication based on our pilot study with CAMH, the Center for Addictions and Mental Health, where we've collaborated on an integrated care program. We've integrated diabetes specialists and a diabetes coach, along with mental health training, with a virtual care team that's optimized and specializes in mental health. So we're looking to augment and strengthen the collaborative integrated care, but also taking advantage of technology to offer this support in otherwise challenging circumstances or limited resource settings. The other thing we're looking at is the use of technology, specifically machine learning and artificial intelligence. And so I say this with a big dose of cautiousness, in that myself personally, I don't see machine learning or AI ever replacing a human. I think there's a lot to be said about human contact. But is there a way that machine learning can augment and further support one human coach? So if we think of sort of a pyramid with 3 levels, we can suppose that people can be having conversations with machines that are adapting based on wearable technology, steps taken, that sort of thing. We certainly do see some of these innovations already in place, like text messages that are acknowledging and congratulating people if they get a certain amount of steps. So can the machine learn some of the behaviors that the coach is doing, the recommendations, the strategies, that sort of thing? But ultimately, is there a way to escalate or flag and escalate individuals all the way up to the human coach, so that that human coach can further protect their time, support people as needed, and then some of that kind of bigger population level coaching can be done or augmented by machine learning and AI. And then finally, what we're thinking about here is, revising coaching as we know it. Currently, I have 2 publications that are under review. One is looking at further revisiting the diabetes coaching effectiveness literature. We're seeing coaching trials that are done in diverse communities, using technologies for different lengths of time. Sometimes they're built off of cognitive behavioral therapy programs, etc. So what we're doing is sort of culling the literature again to just further build on what we know in terms of effectiveness for A1C and also other clinical markers like blood pressure, weight, BMI. Our other publication is also looking at the implementation challenges, barriers, and opportunities. So this speaks to, okay, if we're having a hard time describing health coaching, how might we optimize the training, the effectiveness, the adoption, how they're implemented in current clinical settings? And then how do we maintain this? So in other words, who would pay for the training? Who would invest in coaching and switch the paradigm of diabetes education that's not built around, a vague A1C test that patients go and they have an understanding of where they should be, but it really doesn't mean anything to them on the day-to-day life and self-management. So it would flip the paradigm to really make it individually driven. They call and connect with the coach once a week, once every 2 weeks, once a month. So we're really trying to understand how might this be adopted, implemented, and then evaluated ultimately. The other thing we're looking at is, can diabetes health coaching expand to other populations and models of care? So diabetes prevention comes to mind. And we are looking at a population of women that have experienced gestational diabetes and pregnancy, but looking at health coaching beyond in that sort of 4th trimester. And that work is being led by Dr. Lorraine Lipscomb and her team at Women's College. And, looking forward to exploring that a little bit more in that 4th trimester. We also have the opportunity to explore health coaching or diabetes coaching for diabetes prevention in the pre-diabetes population, and then subsequently diabetes remission. And I'm proud to say that I'm a part of the REMIT team that's located at McMaster University, that is leading multi-component clinical trials at 6, 7, 8 sites across Canada, that is testing and evaluating complex interventions for remission, including health coaching around some of the behavioral aspects. And then ultimately, in terms of revising, it might behoove all of us to think about how we're offering diabetes education in primary care. Particularly, I'll speak to some of the provinces, and in Ontario, inclusive specifically, as we move towards a horizontal integration, if you will, of healthcare services in Ontario health teams. Is there a role for a health coach to help along that spectrum of individuals that are at risk or living with diabetes at this point? So is there a role to embed a health coach in primary care to really help people live healthier lives, regardless of where they are in that diabetes spectrum? And so in conclusion, this whole endeavor for me has been a cooperative enterprise. So I'm always so grateful for the little sort of eureka moments from patients, from my colleagues, who have always supported me, challenged me, have been curious, and have listened. And so again, none of this would be occurring or happening if it wasn't for the cooperation, support, mentorship, guidance, and good faith of all the individuals that have ever helped me along the way. And I really think that health coaching is a cooperative enterprise. It's really about relationships. That's what we're here for, and that's to help people live better lives with, or if they're at risk for diabetes. So to that end, I want to thank you all for your attention. And finally, if anyone has any questions about the content today, or would like to see some of the publications that were discussed or mentioned, please reach out to me at dsheriff@mcmaster.ca, and I'm happy to share some resources. Again, thank you all for your time, and I wish you a good day.
Thanks, Diana. That was great. Just want to run through a few things. First of all, we'd love your feedback on our webinar program. You can scan this QR code, fill out a brief survey. We would love to hear from you. If you enjoyed today's presentation, consider donating to Diabetes Canada. Diabetes Canada, as a registered charity, relies on support of people like you. Consider donating to Diabetes Canada at diabetes.ca/donate to fund all areas of Diabetes Canada's work, including life-saving research to end diabetes and to provide more webinars like today's. If you want more up-to-date information on diabetes care, consider becoming a professional member at diabetes.ca/membership. You get access to the Canadian Journal of Diabetes, a discount to the annual professional conference, and access to an online community of peers. These are all benefits and more of your professional membership. Members are invited to continue the conversation at community.diabetes.ca to chat more about today's webinar. And thank you for watching. If you are interested in finding more webinars and podcasts that we've done, you can go to diabetes.ca/healthcare providers. We have a webinar from Dr. Ronald Goldenberg on recent and upcoming diabetes outcome trials, and Dr. Sean Wharton presented on weight inclusive care. Dr. James Kim and Dr. Aske Jain are doing a presentation on cultural competency, which should all be available already or in the coming weeks. So Dana, thank you again for presenting today. Thanks to everyone who's watching, and we hope everyone has a great day.